Welcome to the Premipod, the podcast dedicated to sharing the powerful, inspiring, and often emotional stories of families and healthcare professionals navigating the world of premature birth.
Whether you're a parent, a healthcare worker, or just someone looking to understand the journey, we're here to offer support and insight, one episode at a time.
So tune in as we dive into real experiences and explore the strength of the neonatal community. We're your hosts, Kirsty, Dimity, and Meg.
Hello and welcome back to the Premipod. Today we have Meg Murphy, who is a neonatal nurse practitioner in the NICU.
Hi, everyone.
Hello.
Hello.
How are you?
Another Meg.
Yes, Meg and Meg. All
Yeah.
right. So today we're talking all about what is a nurse practitioner, how do you become one, and then going from there. So tell us a bit about where you grew up, where you're from, and how you got into nursing.
Okay. Well, I'm New Zealand born and bred.
Yep.
Don't know
As
if
you can tell.
The accent gives it away.
Okay. So I went to school there, and when I finished school, I wasn't quite sure what I was going to do. So I applied to Teachers College to become a teacher
Really?
and nursing school.
Both the Megs wanted to be teachers.
Yeah.
There you go.
Well, I come from a line of teachers. My mother went to Teachers College, as
Yeah.
did my grandmother. So
Wow.
it's kind of natural. Got into both, so I had to choose.
How did you decide? What was the factors?
I really enjoyed science
Yep.
Yeah.
and health and art. So I think nursing is a really good mixture of all of those
All of
things.
them.
I
Yeah.
think that's
Although
yeah.
I do a lot of education in my role as a nurse practitioner now. So
You really do.
You got the best of both worlds.
yeah, absolutely. Yeah.
Oh, that's so good.
Yeah.
So that was in New Zealand, and
New
so you
Zealand,
got
yep.
into nursing school.
Went to nursing school at
Yep.
the tender age of 17.
Oh my
Oh my
goodness,
God.
that's
So
so young.
I know, I couldn't even get into the pub.
And so what did nursing school look like for you in New Zealand?
Well, you couldn't really have a job as well as go to nursing school because it was sort of
Like a full-time gig?
pretty much, yeah. So it was a lot of hard work. I was always it was at a polytechnic, which I don't know.
No.
I don't have them here.
Yeah.
It's similar to TAFE, but they
Yeah.
offer degree courses such as nursing, midwifery, occupational therapy.
Yep.
And I was always jealous of the uni friends because they
Had
didn't
all
seem
the
to attend
spare
very
time.
much.
Yeah. And you were there every day.
Every day, yeah.
So was it like you studied for some days and then you did practical other days, or how
a
did
lot
that
of
work?
stuff? So we went every day.
Wow.
So we didn't do a lot of practical in the first couple of years, and then later we went on clinical placement.
Yep.
So,
Where I grew up. Oh, sorry,
oh,
Meg.
sorry. How long did the nursing school go for?
It was a 3-year bachelor degree.
Cool.
Wow.
Yeah. So there's a medical school in the town I grew up in Dunedin. So big health science area. They have dentistry, medicine, and nursing.
Wow. That's excellent. And so then when you finished, did you go into what was called like a graduate program, or did you just get put somewhere in the hospital? Like how did that work over there?
Yeah, so I was lucky enough to get a graduate nurse position, and I worked in the emergency department.
Really?
Wow.
Yeah, which was
Wow.
amazing. That's where I discovered that I really enjoyed acute nursing.
Yep.
And from there, my dream was to become an intensive care nurse.
Mm-hmm.
And let me be clear, an adult
Adult.
intensive care nurse.
Big people.
Yeah, babies and children were scary to
Yeah.
me. Yeah.
Yeah.
And in hindsight, I think that was just an experience.
Yep. That's excellent.
Yeah.
So did you actually enjoy ED? Like how long did you
Loved
spend in ED?
I was there for 6 months, and then I did acute orthopedics as well. So again,
Really?
yeah, it's a lot of trauma-based things.
Yeah.
Yeah. So
Yeah. And so
Very cool.
then you obviously wanted to get into adult ICU. So
yes.
how did you approach that? And then how did you end up in NICU?
Well, I did up my CV, and back then there wasn't like online application, so I went to the ward to talk to the charge nurse, it was called at the time, and said, "Oh, any jobs going? Here's my CV." Said, "No jobs at the moment," but they took my CV and said they'd let me know if anything came up. And there was a unit next door to the ICU, but it had NICU. What's the N?
What's the N stand for?
Naughty intensive care. I don't know. I asked someone and they're like, oh, it's neonates. And I didn't really know what that was. And they said it's for sick babies. I was like, oh, that sounds awful.
Terrifying.
But then I got thinking, well, it's right next door. And if I got some experience in an intensive care environment, then I'd be more likely to get a job in the ICU. So dropped off my CV.
To the matron,
The charge nurse. And to my surprise, I got an interview.
You're like, oh no.
I don't really want this job, but I need one. So off I went. I wasn't nervous because I didn't
Want the job.
really want it. Yes. Okay. Yeah, it's true. And they offered me the job to my surprise. So
Wow.
that was the beginning of my neonatal nursing career.
Wow.
Wow.
And look where you are now.
Yeah, I really quickly fell in love. I was
Yep.
surrounded by the most amazing, supportive team. Yeah, and haven't really looked back.
Well, do you remember what your first day was like in the NICU? Do you remember what that felt like for you?
Yes, I was far too scared of touching the babies. They were so fragile looking. Didn't want to hurt them. I went to a birth.
On your first day?
Yep.
Oh.
Yep.
Oh my God.
It-
Sorry, how was that?
Oh, I came back and they said, "Oh, you're looking a bit pale, Meg." I had never experienced. We don't do a lot of that in your undergrad degree.
Yep.
It's the same in Australia, I
It
believe.
is, yeah.
So yeah, it was a bit of a shock to the system. Let me tell you.
Was
Do
that
you
the
remember what it was? Like what birth it was? Like was it a high risk one or was it a sort of a simple birth?
a simple birth?
Oh, that's good.
Still horrific.
Yeah. 100%.
I'm never doing that.
That's what I think every time I go to birth. So I think,
Yeah.
oh, I won't be giving birth.
Was that the first time you'd ever seen someone give birth?
Yeah, it was.
Wow.
It's like it wasn't completely horrific. I was
Yep.
just shocked, but also it was a magical moment.
You were
Yeah.
so young though, so
I
Yeah.
was a very naive.
yeah.
Yeah. To be there when someone takes their first breath and to be there in a family's most intimate time in their
Yes.
lives
Yep.
and you're a part of that. So
Yep.
as horrific as it was very special.
Yeah.
Yeah.
And I think too, to be NICU, to be attending, parents really see NICU as like, they're here to save my baby's life. And they're looking at you like,
Yes.
you know,
Yeah.
do whatever you can, you know?
Yeah. And the
And
parents
that's
are
so
almost
amazing.
expecting
And
something
you're-
to go wrong.
Yeah, that's right. And
Yes.
you're not
Yeah.
feeling that way. You're just feeling, oh, I'm going to this birth to see if the baby needs any help. It's not really a big thing, but in the parents' eyes, you like are amazing.
You're their hope.
Yeah, that's
Mm.
right.
Yeah, it's so true.
Yeah.
Yeah. Yeah, that's really true. And so then how long were you like working in the NICU in New Zealand before you came to Australia?
So it was about 3 years. I went on to do my postgraduate certificate in neonatal care.
Yep. You loved it that much, hey?
I loved it that much.
So
I
the
did.
ICU, adult ICU was just swiped.
Yeah.
Yeah,
Like
it was.
day
No
one,
thanks.
No good.
see you later.
Well, I did a stint later on in life when I moved to Australia, and I quickly learned that babies are for me.
Yeah. Mhm.
Isn't that interesting?
I think it's
Yeah.
great that you
Wow.
did go back and do the adult ICU, so you're never wondering,
Yeah.
and
Yeah.
then you realize like, no, I'm supposed to be in NICU.
That's absolutely, it consolidated where I wanted to be. And it's more than just a career. It's
Yeah.
becomes your identity.
Yeah,
Yeah,
it's your
that's
life.
right.
Like you're a neonatal
Yep.
nurse.
Yeah.
Yeah, absolutely. So what made you move to Australia?
Depends who you ask.
Give us all versions.
If you ask my husband, it would be to find a sexy Australian husband. That's not my version.
It's a good one.
Oh, look, it's actually maybe my mum was trying to get rid of me. Just kidding, mum.
Ship you off.
Love you, Mum.
She found this job. I really wanted to become a neonatal nurse retrieval.
Yeah.
And there was a small retrieval team in the unit that I worked at, but you basically had to retire or die to get on the team.
Uh-huh.
So my mum said, hey, here's this job in another country.
Easy peasy.
Yeah. So I thought, okay, that sounds all right. I'm not a big city girl, so it wasn't in a big city, but it was in a neonatal unit that had NICU, special care, looked after premature babies, surgical babies, and ran an aeromedical retrieval service. So
Bit of everything.
bit of everything, yeah.
Yeah.
So much like how I got into it, I thought, oh, well, throw my hat in the ring. I applied and got an interview, phone interview.
It's amazing.
Yep.
Yeah.
Got the job, and on Anzac Day 2007, I flew across the ditch to Australia.
Oh
Wow.
my goodness.
By yourself.
Yeah, I was really brave.
Oh my
back then.
gosh.
That's scary. That is very brave.
Oh my gosh. I
Yep.
don't think I could do that by myself.
Did you just have a suitcase and then
Just
that's
one little suitcase.
Wow,
Yeah.
Meg.
Did you know anybody in the
No.
town that you were going to? Nobody.
it? Oh my
Nobody.
gosh.
That is
Wow.
very brave.
Yeah.
Wow. And so
Yep.
the job you applied for, was it a registered nurse position?
A
was
registered
it,
nurse
Yeah.
position.
Yeah.
Yeah,
Yeah.
absolutely. So I hadn't been in any leadership roles or anything in my career at that stage. So it was a big jump just to leave the country, I guess.
Yeah. And where did
Huge.
you stay? Like you came to Australia. Did you have places booked to stay already or
No, so part of the job I got put up in accommodation at the hospital. So that
Oh,
was
that's
paid
good.
for sort of 6 weeks until I found somewhere to live.
Mhm.
So that was good. I didn't take long to get to work.
Yeah. I can
Just
be
a
on
quick
call.
walk.
Yep, yep.
Yeah.
Yeah, so
Yeah.
it was good. It was a bigger unit than I was used to,
Yep.
but I loved it straight away.
Did you notice any differences in how they provided neonatal care between New Zealand and us?
Yeah, absolutely. So the medications were a little bit different.
Yep.
We were using caffeine citrate for apnea of prematurity already in New Zealand,
Yep.
and we were using sucrose for pain relief. And when I came to Queensland, they were still using aminophylline and theophylline.
Yeah, right.
Yeah, well, we
you
don't
girls
even know
probably
what that
haven't
is.
heard
Yeah.
Do you know
You're
what's
too
funny?
young.
Do you know what's funny? Last night at work, I literally had one of the old school nurses say to me, "Oh, these babies are just on aminophylline and Infloran," and I was like, "From context clues, I know you're talking about caffeine, but I've never heard
Yeah.
it called that
Yeah.
at all."
Yes, I'm an
Me
old school
either.
nurse. Yeah.
Wow.
Yeah. So that was different for me.
Yep.
And just a few different things. But essentially, the care was the same.
Yep.
There was more space. The unit I came from was very small. So, and it was a lot busier.
Yeah.
Really interesting.
Yeah.
Yeah, great.
Yeah.
And so then what made you want to become a nurse practitioner? How did you even find out about that role? And, like what even inspired you to become a nurse practitioner?
So when I was doing my postgraduate certificate in New Zealand, I had heard of this master's to become a nurse practitioner, but I didn't really know what that meant. I didn't know any nurse practitioners. I thought that sounds hard. There weren't really any jobs for neonatal nurse practitioners at the time. It was really quite a new role. So it was the unknown, I guess.
Yeah.
Did that hospital help support you through that?
Yeah, they did.
Yeah.
When I came to Australia, I met someone training as a neonatal nurse practitioner, and I thought, well, that looks like a really cool job, but it looks like a lot of responsibility.
Yeah.
I
Because
never imagined doing it.
I guess in the NICU, it's completely different to the outside wards in the way that our emergency team is in the unit ready. So it doesn't come from somewhere else. So I think we should explain that to the viewers a little
what
bit.
is a nurse
Yeah.
practitioner?
Okay. So a neonatal nurse practitioner or just nurse practitioner?
Neonatal.
Neonatal.
Neonatal nurse practitioner. Okay. So it is essentially a neonatal nurse with an extended knowledge base and experience. We perform advanced skills that quite often are thought of as in the medical domain, such as intubation, so putting a airway in, inserting central lines, ordering x-rays, prescribing medications. To become a nurse practitioner, you need to have a master's in nurse practitioner, and you need to have over 5,000 clinical hours of advanced practice.
Wow. That's a
Yeah.
lot.
Yeah,
It
that is a
is.
lot.
Yeah.
Yeah.
Yep.
Yeah. That's amazing. And I think, like you said, it's a very new role. Do you know a little bit of a background about how nurse practitioners even came to be?
Yeah, okay, well, now I know why you invited me. You've got the old school nurse with some history lessons.
We do. We need to know it all.
Well, I've got a little story that's kind of close to my heart because it's about where I grew up.
Yep.
So I grew up in Dunedin, which is at the bottom of the South Island. It's very cold, but a beautiful place. And in the early 1900s, there was a man called Dr. Truby King. And he had a holiday home just outside of Dunedin in a town called Karitani. It's a little seaside village. And in his holiday home, he started taking in babies that were either abandoned or they were born early or they were malnutritioned, like what we'd call failure to thrive now.
Yeah.
So he would take in these babies into his holiday home and their mothers, and then he hired these nurses to help him look after these babies and get them putting on weight, help them feeding, and with the aim of returning them home healthy. This got bigger and bigger, and it was known as a Karitani hospital because that's where the place is. And it was really successful, actually. So in the end, they opened 6 of these Karitani hospitals throughout New Zealand.
Wow.
Yeah, and their whole aim was to care for babies.
Mm-hmm.
They even created a special formula to help grow the babies or supplement mum's breast milk. And
That's
have
amazing.
you heard of Curry Care?
Yeah.
Is that where it comes from?
That's where it comes from.
Wow.
Oh my gosh.
There you go.
Amazing. Did
Yeah.
not know that.
Yeah. So my auntie actually trained as a Karitani nurse.
Oh my
Stop it.
gosh.
Yep. Shout out to Auntie Sue.
Auntie Sue.
Thank you, Auntie Sue.
Yeah. So yeah, that's a little bit of history there from a local perspective. But the role of a neonatal nurse practitioner actually sort of comes out of the States.
Yeah.
So we probably should talk a bit about that. I don't know.
Yeah.
Yeah.
So there's a few things that happened early, about the same time as Truby King was taking in babies and looking after them. There was actually a guy called Martin Cornet, and he had a sideshow at the Coney Island in New York, at an amusement park.
Yeah, right.
This is a true story, Google it. And there at this amusement park, patrons paid 25 cents and they would come through. It was a really popular exhibit, all right? And they lined up and through glass, they would look at these premature babies.
Gosh.
You were
And
joking.
they paid to look at these premature babies in a sideshow.
You are joking.
It was called...
What were they doing? Like, were they just in their beds or
Yeah, they were in
isolates or
beds, and then so to look after them for the sideshow because he was making money out of it, he hired these nurses and wet nurses. So wet nurses is lactating mothers to provide breast milk to look after these babies because they were making him some money, right? Yeah. So
where did the babies come from? Do you know?
So they were often orphaned babies, but parents caught on. So sometimes when babies were born early, there wasn't a lot that could be done for them. So parents would bring their babies to the sideshow in an amusement park
Coney Island.
at Coney Island, New York. It would, and they'd
Wow.
get into this exhibit. And what actually happened is they learnt how these babies would survive. The ones that were kept warm, the ones that were kept on breast milk survived. Okay, so
Wow.
it's, it's today, pink, warm and sweet, right?
Yeah.
So they actually found that these things were working and the babies were surviving. And the Lancet, the medical journal,
Mhm.
Oh, no.
Yes.
the Lancet.
Yep.
So it's a pretty prestigious medical journal. They cottoned on to about this work that was happening in the sideshow, and they published an article about the work that he was doing. And
Wow.
yeah, pretty
That's
cool.
Crazy.
Amazing.
All I'm imagining is like Dream World with like a side with babies. on
Step
top.
right up.
Yeah.
And then I guess fast forwarding into the 60s in America, a pivotal event that happened then was, you've heard of John F. Kennedy, the American
Yes.
president? Yeah, okay. So he had a son called Patrick.
Yep.
And Patrick was born early at 34 weeks. And these days, 34 weeks,
Yeah,
it's
no problem.
no
Yeah.
problem, right? And the literature says that he had breathing difficulties. So he was born at an Air Force hospital, and then he was transferred to the Boston Children's Hospital for his breathing difficulties, and he passed away, sadly,
Wow.
after 9
Wow.
hours.
9
Wow.
hours.
9 hours at 34 weeks.
Which that's crazy because, like you said, if a baby was born at 34 weeks now, it's like
Yeah.
very, very good.
Yeah, very high chance of survival.
Yeah.
So back then, they didn't really have any treatments. They weren't, antenatal steroids weren't a thing. Surfactant wasn't a thing.
Yeah.
So there was this public outrage that even the president of America, his son couldn't survive. So there was some funding raised,
Yep.
and they started doing some research into advancement in neonatal care. And it was sort of essentially where the medical specialty of neonatology started taking off. So what happened was that premature babies' survival started increasing once the funding got going and technology was improving, and then there was a shortage of doctors.
Mm-hmm.
There comes the neonatal nurse practitioner. Okay, so that's where the role sort of came out of. And no, we aren't just junior doctors, but that's essentially what happened. So there was nurses when the doctors weren't available that were performing advanced skills outside of their regular scope to help babies. Because it's very specialised, obviously.
Extremely.
Yeah.
Yeah.
So
That's amazing.
and then, good things take time. So another 30 years, Australia cottoned on. And the role sort of started expanding here. So, yeah.
And where you work right now, is it still relatively new there, like in the grand scheme of things, or have they actually been using it quite for a while?
Yeah, so where we work, we actually have 7 neonatal nurse practitioners, and we've trained many more that have since moved on to other places. And we've probably had them for at least 15 years, I would say, working there. Us.
And would you say 7 is a lot for a NICU unit? Is that high compared to other units?
That is a high number compared with other neonatal units for the comparative size of where we work. We had them earlier than some other units in Australia as well. So
that's awesome.
Yeah. And again, it actually came out of, unfortunately, a shortage of doctors. So it was hard to get specialised doctors into regional parts of Australia. So the role had some funding to get going in these regional areas to start with. So doctors have to do a lot of sacrifice, a lot of study and things like that, but it's very generalised, whereas we're almost are educated backwards, if you want to say it like that. So we are experienced, we recognise patterns, and then we advance our skills, and then we go on to do advanced procedures and things like that, whereas doctors come with all of the knowledge but little experience. So I'm not sure where the funding actually comes from in the current unit that we work, but we do work on a medical roster. So there's 7 neonatal nurse practitioners and 4 to 5 registrars, so paediatric trainees. And we work with 6 incredible neonatologists.
Oh, very nice.
And many, many amazing neonatal nurses.
Stop it. And those registrars, they rotate through, don't they? So they're not just there. They do like 3 to 6 month rotation, sometimes 12, but they're always rotating, aren't
Absolutely. So the senior registrar position is anywhere from 12 to 24 months. And at a registrar level, it's 3 to 6 months. So they just rotate. They're only there for sort of a short amount of time, and there's a lot to learn. But I always learn something from them. They've always got something to teach. And I think it's a really important role, even if they're not interested in going into the neonatal field. And at the end of the day, as a paediatrician, to have that experience working with babies is super important.
Yeah. Because I even know just for us, we love the consistency of the nurse practitioners. You're there all the time consistently, whereas it's really hard with like a revolving door of registrars to get them into the experience, but then also up to date with how we do things in our specific unit. Like we are so appreciative of you guys. Like you really have stability in the unit. Like we would say that's probably one of the biggest things that we look at with the nurse practitioners. How important would you say the nurse practitioner role is in the NICU unit?
Oh, that's hard. I guess it's a big part of if you want to say, the medical workforce. There's more neonatal nurse practitioners than there are registrars, but at the end of the day, we work under a neonatologist. So there's always somebody supervising our practice
Yes.
that we can consult with. I guess it is important. We also go to high risk births. We work in the special care nursery. We work in the neonatal intensive care. And we also are part of a retrieval service that is nurse practitioner led.
Yeah. And is that unique to the hospital that you're working at now? Do other units around Australia also have a similar structure?
Yes, so there are other neonatal nurse practitioners working as retrieval nurses. Some of them aren't standalone units, so they're not run out of the actual NICU themselves. So that's their primary role. That's all they do. I've got some wonderful colleagues all around Australia, down south in Melbourne and Brisbane. WA have got their first neonatal nurse practitioners as well. So it's super
Wow.
exciting. South Australia, Newcastle, shout out to everyone. Yeah, so Sydney, it's getting bigger and bigger, and it's super exciting. And I feel so privileged to have that role title.
Yeah.
Can
Yeah.
you tell us a little bit about what retrievals are?
I know I keep using it so broadly. Essentially, retrievals is moving or transporting a baby from one healthcare facility to another. That can be in an ambulance or in a fixed wing aircraft, an aeroplane, or helo, as we say in the industry, a helicopter.
And why are we transferring the baby from one place to another?
Absolutely. So when the baby is born, if their healthcare needs are outside of the clinical capability of that facility, they need to be moved to another hospital that can care for that baby safely.
Yeah.
Yeah. Another part of my role, I talked about education. As well as educating locally, I'm really passionate about outreach education.
Yeah.
What that means is that to ensure smaller places or clinics or hospitals can safely birth. So where we live, there's a high proportion of First Nations people, so Aboriginal and Torres Strait Island people. It's very important about birthing on country.
Yeah.
Okay.
Because we have a lot of rural towns, with small hospitals or no hospital at all, really far from main hospitals that can provide neonatal care.
Yeah, unlike some of our states down south where there's many level 6 NICUs in a big area, our closest level 6 NICU is about 1,400 kilometres away.
Yeah. That's very far.
All right.
So far.
That is not an ambulance trip for us.
It's a 2-day ambulance trip.
Yeah.
That's a Learjet.
If you're lucky.
If you're lucky. That's right. So what we need to ensure in these places is that when the babies are born, and if they're born early and there's no time to move the mum, or what we call an in utero transfer, if the babies are born in these facilities, that the staff there are capable to safely look after them until the retrieval team or comes to look
Angels
the
arrive.
angels. Yeah, so I'm quite passionate about this outreach education, and in a couple of weeks I'm heading up to the Torres Strait to a hospital on Thursday Island, and to provide neonatal resuscitation and stabilisation education.
Wow.
That's amazing,
So
Meg.
I'm really excited about that. These places do a fabulous job, often with a lot less resources than we're used to.
Yes.
But when help is that far away, they need to be prepared and educated to do things that they're not used to doing.
Absolutely. Yeah. And you're so right. Even just depending on weather, it could be sometimes a long time away for us to get there. Those nurses and doctors must be so scared. How do you find the education? Are they really, wanting to get the most out of it? How many people kind of attend? Do you get people from like GP clinics attending, or is it mainly just hospital? Like, who are you mainly educating?
Mostly the people that we go and see are either general ruralists, rural generalists, I should say. anaesthetists or obstetric trainees or midwives, a lot of midwives, and they have to sort of be a jack of all trades. So they are incredible people that do a lot of work, a lot of MacGyvering. Yeah, it's fascinating. They're always so receptive to the education, and most of them have something to teach me too, which is really special. There's no point in telling them, or just pop the baby on some high frequency and some nitric oxide. Oh, what? We don't have that.
Yeah.
So they could be hand ventilating a baby for our average
Hours.
retrieval time is 6 hours.
Wow.
Okay.
Wow.
So if you think about that, by the time that's average.
Yeah.
There you go.
Yes.
Those nurses and
Yeah.
doctors are amazing. Like,
Yeah, they are.
And plus, like you said, they have to do a bit of everything. So even resuscitating a baby, that's with completely different devices that they're used to using. So teaching them how to use those really well is really important.
Yeah, that's exactly right. So using their resources, their
Yeah.
equipment to
Yeah.
provide the care. And they've still often got the two patients. They're still caring for the mother as
Yeah.
well.
Yeah.
They're really small teams, so expected
Yeah.
to do a lot. Yeah.
Yeah. Have you ever felt like you've had to prove yourself or your role either in a hospital or on a retrieval? Do you ever feel like people don't respect the role of a nurse practitioner enough?
Yes, many times.
Mm.
Some people don't know what a neonatal nurse practitioner is. And I've got one example. We went to a facility. I was the nurse practitioner, and the team, when we go on retrieval, is either a nurse practitioner or a doctor and a nurse.
Mhm.
So the team on this retrieval was myself and a very experienced neonatal nurse who is now a neonatal nurse practitioner.
Mhm.
Fantastic.
So we were going for a woman in labour, and she had a baby that had a congenital diaphragmatic hernia.
Wow.
So stop
So-
there for a
okay.
second. Explain what
Yes.
that bit is before you go on.
Okay, so a congenital diaphragmatic hernia is when there is a hole in the diaphragm. So the diaphragm is that big muscle that separates your abdomen from your
Yeah,
chest
so-
cavity.
Yeah.
Yep. And there's a hole in there. And then what happens is that your abdominal organs, so your intestines and your stomach and sometimes your liver, goes up that hole and fills the chest cavity. And what that does is it essentially squashes the organs in your chest.
Mhm.
Now, those organs in your chest are pretty important for survival, such as your heart and lungs.
Yes.
So these babies, when they're born, can be very, very, very unwell. And the best chance they have of survival is to be born in what we call a tertiary centre. So they need to be born in a NICU where they have access to a paediatric surgeon
Yep.
and the highest level of neonatal care. That's not always the case. Sometimes these women that live regional might go into early labour. Sometimes they don't know that the baby that they're carrying has this condition. So there can be a number of reasons why these babies aren't born in a tertiary centre. And that's what happened in this case. The lady went into labour in a regional facility. So therefore the neonatal retrieval team was deployed and off we went.
Yep.
Were you nervous? Because like I know where I work now, even getting diaphragmatic hernias, it's like, oh my gosh, is this going to be good? Is this going to be bad? Like, it's really touch and go, and it could be either way.
Oh, I was terrified. In fact, my boss said, "Stop being so ridiculous."
You'll be fine.
You'll be fine. Yeah. So, it's just unexpected. So they can be born really, really, really sick.
Yeah.
But I've had a lot of experience. I've looked after diaphragmatic hernias before, but when they're born in our unit, I've got a neonatologist on hand.
Everyone's
Yes.
There's a big
You know,
support team.
I've
The
got
whole
lots
team.
of support. So what we worry about with these kind of babies is obviously an airway.
Yes.
We try not to provide intermittent positive airway pressure, so we don't resuscitate them with a bag mask or a Neopuff, a T-piece resuscitator, because what that does, it puts air into the gut or the intestines, and when that's sitting in your chest, it further squashes those vital organs, your heart and your lungs. So these babies, if they need help with their breathing, and most of them do, they need to be intubated immediately. And they often get a condition known as pulmonary hypertension.
Yep.
So what that is where there is a perfusion ventilation mismatch, essentially. So the blood vessels going to the lungs aren't working as well as they are for a few reasons. And what we need to do is provide a special gas that goes into the ventilator circuits known as nitric oxide. And that helps relax those pulmonary vessels for gas exchange. It dilates them and makes them bigger and makes them function a little bit better.
Yep.
The other problem is your cardiac output. So when your heart's squashed, it doesn't pump effectively. So that's the other problem that you have with these babies. So that they're the sickest of the sick, really. They
And
are.
I guess lucky you did know that it had a diaphragmatic hernia, because in our unit there's 2 different retrieval cots. Only one can have a nitric setup.
Yes,
and
that's
that
right.
you knew that the baby had a diaphragmatic hernia was really great. So then you could take that and you can be prepared.
Yep, absolutely.
For the worst.
So we took the nitric oxide cylinder with us, and off we went. Getting back to your question, Kirsty. So when we turned up, the baby wasn't born yet, and the team at the regional hospital was trying to suppress the labour. Well, I went to speak to the family, and the mum was fair cracking on. She was contracting regularly. I'm thinking we're not going to be able to move her. So I went to speak to the obstetrician. Now, he was an older gentleman. And he sees that I have nurse in my job title, and I'm with another nurse, and he says to me, look, I'm sure you can resuscitate babies okay, but I was expecting a doctor, not a nurse. That's what he says to me, and really I wanted to cry.
That's terrible, Meg. I'm sorry that happened.
Oh, no, that's okay. So my job is to describe what I do, what my role is. I told him that I'm able to care for a baby with a diaphragmatic hernia, that I have experience doing that, and that my boss and my unit wouldn't have sent me if he didn't have faith in my skills and my ability to safely transport a baby like that.
Yes.
It was quite obvious that the mum was not in a position to be moved to a tertiary centre, so we waited for the baby to be born. But there was just a lot of pressure, I guess. I'd had someone that didn't think I was up for the job because I was a nurse practitioner.
And even though you are very capable of that, when somebody says that to you, you're like, oh my gosh, I don't want to do the wrong thing, or something could happen that's completely out of your control, and then you feel like horrible because somebody said that to you previously.
Yeah,
and it puts the extra amount of pressure on as well, because you're feeling like you have to prove yourself instead of just do your job to the best of your ability, you know?
That's right. So I just had to focus on what I was doing. I had a really experienced neonatal nurse with me. I couldn't have asked for a better team that day. And the staff at the regional facility was amazing as well. Everyone just chipped in and we got things done. The baby was born in poor condition, required emergency intubation at birth. And we took him back to the nursery in the facility and started the nitric oxide. We ended up having to use a muscle relaxant to try and ventilate the baby. So we ran a vecuronium infusion. So we had nitric going, and we needed to start some inotrotes. We used dobutamine to increase his cardiac output. And we headed back to the tertiary centre where he could be seen by a paediatric surgeon and have the hole in his diaphragm fixed up.
And I'm sure you showed that doctor.
Who
was boss?
You proved yourself.
I was exhausted. I'd already done a 10-hour shift by the time we got sent out on this retrieval. So it was probably about a 20-hour shift. But
wow.
That's a long shift.
Yeah, it is. But the adrenaline keeps you going.
Yeah, that's right.
Yeah.
Absolutely. No, that's amazing, because I always feel like sometimes people don't understand the role enough, and they don't give you guys credit where credit's due. You often are doing so much work in the unit. You're putting in a lot of the lines, they're intubating a lot of the babies. you're writing up medications, fluids, like reviewing babies, like your role is so much. I feel like you don't get enough credit for what you do.
Yes.
And we really appreciate everything that you do, like all the nurse practitioners, you know,
yes.
it's
Thank
a
you.
really, really beautiful role in the unit. We
Yeah.
really, really love it.
Well, it
Yeah.
is the best job in the world.
Yeah. Hashtag best job in the
Hashtag,
world.
that's right. I mean, even just yesterday when I was rostered to the special care nursery, our father wanted to speak to a doctor. So it's up to me. Look, there's not a doctor rostered on today. I've got a consultant you can speak to. I'm a nurse practitioner. What that means is that I'm running the ward round down here today, and I'm happy to speak to you about the condition of your baby and any questions that you may have. And if I can't do that, then I can get my boss to come and talk to you. And once you explain that to them, you know, most people are okay with that. So
Yeah.
Yep.
I guess most people don't really know that what a nurse practitioner is. So I guess that this podcast will help, you know, get
I
them
hope so.
the word out there.
Absolutely.
Yeah.
They are all amazing. That's what I'm going
Yes,
to say.
they are. They're the angels of our unit, seriously.
It is a great job. And we are in the process of training another 7, I think, is it?
Wow.
Yeah, wow.
6. Yeah.
That's a lot.
It's getting more and more popular. I'm not sure whether we'll have jobs for everybody, but the education's amazing.
You guys you know so much and you do so much. And I know that I speak on behalf of myself, Dimity, and Kirsty. We all look up to you so much. And you've taught us heaps.
Yeah.
Oh,
Yeah.
thank you.
Yeah.
I really do appreciate that, girls. I was in another leadership role before I became a nurse practitioner. I was the NICU CNC, which is clinical nurse consultant. But it wasn't as clinical as I wanted to be. So I did that it was about 9 years before I decided to undertake my master's to become a nurse practitioner. And I've never looked back. So I'm so glad my mum found me a job in another
Thanks,
country.
Mum.
Yes.
Thanks, Mum.
Shout out, Mum.
Meg, we have some questions. So with your job as neonatal nurse practitioner, you've implemented a lot of things in the unit. One of them being maintaining babies' temperatures coming from birth to the NICU. So can you tell us a little bit about that? And
Yeah, sure. It'd be my pleasure. So some of the things that I'm interested in particular is evidence-based practice and quality improvement. So the aim of things like that is just improving outcomes for our babies. So that's what we all want, isn't it? Yeah. So we recognised that we were having a high proportion of babies that had low temperatures on admission. And I think that it became just a culture of, well, you know, theatre's cold. Of course they're going to be cold. Or this baby's only 700 grams. Of course it's going to be cold. I was reading about it and I read a statement that said that for every degree under 36.5 degrees, your risk of mortality and morbidity, so having bad outcomes, increases by 30%.
Wow. By every percent.
Yeah.
Wow.
Oh my gosh. Yeah. That is
So
scary.
every degree. Yeah.
Mm-hmm.
So that made me think, well, this isn't good enough.
Yeah.
Let's do something about it. So I thought, you know, do other people have this problem? And what have other people done about it? So I did a bit of a literature review and I talked to my friends in other neonatal units to find out what they've done. And we decided to have 4 strategies to try and increase our admission temperatures for the babies. It is collectively known as the SNUG project, which stands for Sustaining Normothermia Unit Guide. And the 4 implementation strategies we selected were, number 1 was increasing the temperature in theatre. So apologies to all those anaesthetists, obstetricians, midwives that are roasting in there. So the World Health Organization recommends an ambient room temperature of 26 degrees.
Yeah.
And went in there and measured actually how cold is it in there, and it was actually like 19 degrees.
Oh my gosh.
Yeah.
And not only that, in the room that you are in, mainly in theatres, is a separate outside room. So they have the vent coming down
That's
on
right.
you, which is blowing cold air straight onto the baby.
That's right. So that was creating further heat loss as well. We also found that using what's called an exothermic mattress, which essentially is, you can just use a warm gel pack if you wanted to, but it's a special little mattress that you crack open, a special gel comes out and it warms up. And that's to help prevent radiant and heat loss.
Yep.
So what we do is put the baby on the warm mattress, so it's going onto a warm surface, and then we have the radiant heater on the resuscitator as well.
On the snug.
On the snug, yeah. Or the midwives sometimes call it Big Bertha.
It is massive.
It's big.
It is big. So that was another change. That was introducing the shuttle, which makes it Big Bertha, the snug. What that means is that we have a continuous heat source. So we've got the radiant warmer on while we're resuscitating. However, on the way back to the NICU from the theatre or from birth suite, there's no heat coming onto the baby. So the shuttle provides, it's got a battery system and provides the heat for the babies.
Yep.
And the last thing we implemented was heated and humidified gases for resuscitation.
Yep.
So that was using a humidifier for the T-piece resuscitation circuit. And when the gases are coming out of the wall for resuscitation, if you don't heat them up, they're about 14 degrees. And that's going straight into a little preemie's airways. And we know that's not good for the cilia and all the little airways. So what we did was heated them up, humidified it. So now it's going to the baby's target temperature of about 37 degrees. So that was sort of the fourth strategy we chose to use.
How did you narrow it down to those four? Was it from your literature review? Was it from what other hospitals had been doing? And which ones didn't you include? Were there other ones that you thought you might have wanted to?
Yeah, it was from, there's a neonatal nurse practitioner special interest group. So I spoke to other neonatal nurse practitioners to find out, were they having cold babies? Have they had a problem with cold babies? What did you do about it? And some places did already heat their theatres up. I didn't even know we had the capability of changing the temperature.
neither.
So
Of like each room too. I would have just assumed they're all connected up to the one system and then that's what you got.
that's right.
Yeah.
I do know that some older healthcare facilities don't have the ability to do that, so they've had to come up with other strategies. There's other units that have been using the GE shuttle for a lot longer than us. So.
I actually went to a birth the other day and we were using, I don't know what exactly it was, but it was something for adults and it was like a big
or the bear hugger.
Yeah, and they had two of them
Yeah.
just going and putting out hot air into the theatre, which was really good.
Amazing.
Yeah.
Oh, maybe you should invent something like that for the babies. Yeah, so that's how we thought we'd just stick with 4 to see how we went, and we measured all the admission temperatures over 12 months, and we actually halved the number of cold babies that we were having.
Amazing.
Yeah, so that was super exciting. That was a big change in our practice, and at first people were kind of like, oh, this is a bit different. But now it's really exciting. You'll go to a birth and, you know, the midwife will be like, oh, I've already asked them to turn up the theatre temperature and are you bringing the snug around or do we need to bring our own resuscitator? So it's become accepted practice and that's what I really wanted. So that was really exciting.
Yeah, it's great that everybody's got on board.
Yeah, and we actually found something interesting alongside it when I looked at all the babies. So for those babies that didn't get those interventions and were cold on admission, they were twice as likely to have an intraventricular hemorrhage, so an IVH, which is bleeding inside the brain. So you were twice as likely to have the bleeding in your brain as a premature baby. We looked at the less than 32 weeks if you didn't have those interventions.
Just take it to less than 32 weeks.
That's correct. Yeah, less than 32 weeks or less than 1,500 grams. And those 4 interventions doesn't exclude the plastic wrap and the hat and those sorts of things that are part of standard practice. They were on top of all the things we were already doing. So, I'm really proud of the team at the facility in which I work. It's a really, really simple thing.
But it makes a big difference.
It can make a big difference. So, yeah, it's pretty exciting.
Yeah.
Yeah, and you're always going to have those people that are like early adapters and they want to do it because they're excited about it, and they're going
Change
to
agents.
yes, and then you get those
That's the three of
ones-
you.
and then you get those ones that are a bit hesitant. They're like, "Oh, we've never had to do this before," like. And,
That's right.
And so then you get sometimes early on a bit of a disengagement with the project.
Absolutely.
So how did you deliver the education in the unit? How did you inspire people to do it, and then just have it become normal practice?
Guilt. I made people feel bad. No, it's terrible. I think when it was, the babies are going to be cold. They're small. They're born in a cold place. We'll just warm them up. And when I actually said, we could be doing them harm. We could be actually making their journey slower, increasing their length of stay by not having them on when they hit the NICU. So we started with that and evidence-based practice. So after the literature review, and then what I did, I don't know if this is a very nice thing to do, but in the tea room, sorry everybody.
I remember this.
Yeah.
I shamed people. No, just kidding.
Named and shamed.
She put her ladybugs up.
Yeah, I did. I had our admission temperatures for the month. So I would put up the baby's gestational age, their birth weight, and then what their admission temperature was. So
Perfect.
you got a blue ladybird if you had a cold baby, and you got a pink one if it was warm and within target temperature, and then you got a red one if it was too hot.
Nobody wanted that blue ladybug.
no.
I'm telling you right
Or
now.
de-identified, but everyone was like, oh, who was that?
But it was a thing, Meg. Like, I would go to a birth and I would be like, I want this baby to be perfect so that I get a pink ladybug up on the board. Like,
Or like if you've got twins and you've got one team on one baby and one team on the other, you're like,
Competition.
my baby's warm, what's yours?
Yeah,
Yeah,
that's
exactly.
exactly right. And it'll be confession time in the tea room as well. People, okay, so it was only 36.4, but I didn't get a lot of notice, and this is what happened. And
And the theatre refused to turn their temperature up to us. Or as soon as the baby was out, they made it cold again.
yeah. So it was a bit of fun, and now I don't really have to do that because everyone knows how important it is.
Yeah,
So-
and it's just standard practice now.
It is.
Like
Yep.
nobody even questions it.
Yeah, and I think too, Meg, speaking like on my behalf, because of the person that you are, and we have a lot of trust in you. So like anything that you bring out, we're like, okay, amazing. Yep. There's no questions asked, So I think you probably would have felt that too with most of the girls with implementing this snug, that it was pretty receptive.
Oh, absolutely. And that it is. I wasn't joking when I said about change agents, nurses like yourselves, so targeting you, because then when I'm not there, I can't be there 24/7.
Yeah.
You're educating everyone else around you. You're making sure that equipment's set up and ready to go when you're on for admissions, and pulling people up. Hey, well, you better go and get that before we head over to theatre or things like that. So thank you for your support. You've made a difference.
And thank you for implementing this. You're making not only the babies' lives better, but the parents' lives and the nurses' lives. And it's a big difference. You made a big difference in the unit.
Oh, it's simple things that we can change to improve the outcomes of these babies. So start small.
Yeah. And then did you get to present this data at a conference or anything?
Yeah, I made a poster and
Love the posters.
made a poster. There is a conference called the Clinical Practice Improvement Conference, and every year it's held in Manly, New South Wales, and it's a really awesome conference because it's not there going, hey, look at all this amazing stuff we've done. It's people saying, look, we found that we had a problem with this, and this is what we did about it. It's about professionals in the field sharing their ideas because we all have the same goal, and it's improving the outcomes for neonates. It's 32 units from all over Australia, NICU. I think there's some from Singapore. Wow. And what we do is we collect data and we look at our outcomes and look where we're doing well. And our unit wasn't doing so well with our admission temperatures, but because we're collecting that data, it gets recognised and we can do something about it.
Yep. Right, Meg, what is your favourite condition and what is your favourite gestation?
Okay.
because we know from the start you really do love the adrenaline. Why you wanted to be in the adult world?
Yes.
I actually probably at both ends of the scale. So I really am passionate about the extremely preterm babies. So I'm talking your 22, 23 weekers, so less than 24 weeks. It's a really exciting area in the way that we're learning a lot about it.
Yeah.
I believe you're going to have a guest on the Premi Pod that will talk more about that from their own personal experience. So I won't talk too much more about it.
So I guess even when I started in NICU, it was only 24 weekers, and now we're looking at 22, 23 weekers, and that's crazy.
Absolutely crazy. And 22 weekers aren't just small 24 weekers. They are so physiologically different. And they require different care. And we're still learning. We really are. And every special baby that's born less than that has something to teach us and their family. And we just learn. The Japanese actually have a really good survival rate for these really extremely tiny babies. So they're less than 24 weeks, around 80%.
Wow.
Yeah.
Wow.
That's amazing.
Does that blow your mind?
Yeah, it does.
I feel like ours is around that 50% mark. Is that right?
Yes, that's correct. Yeah, that's correct. It's a space that will be rapidly changing. There's a lot of work going on behind the scenes nationally. There is a special interest group from experts all around Australia for this, in which I'm lucky enough to be involved with.
Of course you are.
What are the
You
key,
should be.
do you know like the key things that they do differently to change the statistics?
Okay, yeah. So I know you guys are huge fans of the family-centered care. This might blow your mind, but they actually don't get the babies out of the incubator for a very long time.
Yeah.
So they are usually intubated immediately. They are kept in the midline. They don't move them very often at all. They have
So midline's just laying straight on their back?
they're midline. Yep, straight, head up, on their back.
Yeah.
So not even head to one side or anything, like they're directly midline.
Correct.
Wow.
They nurse them in very, very high humidity in their incubators to decrease insensible water loss. They are quite fascinated with regular bowel movements as well. So the more premature you are, you're at risk of a condition called necrotizing enterocolitis, which can be fatal. And the Japanese will give enemas to regularly ensure that bowels are moving on these little babies. Yeah. So sometimes the parents in Japan, they don't get to hold their babies for a very, very long time. They are also very fastidious about their infection control practices. So they're just some
interesting
key points
Are
there.
we talking like weeks that they can't hold their baby, or is it just like
Could
a
be
couple
weeks.
weeks? Wow.
Yeah.
Okay.
Yeah.
Which I guess in the long end game, like a couple of weeks is very, for the parents, is like they're probably dying to hold their baby, but that they'll get to hold their baby potentially for the rest of their life is, I guess, the key point.
Absolutely. And I'm certainly not advocating against skin to skin or kangaroo care at all.
Yeah.
I think these babies are just so fragile, their skin, the equipment that's keeping them alive.
Yeah.
We don't want to compromise that. So that is just some of the things that the Japanese.
Yeah. Wow. Interesting.
Yeah. So they are world leaders. We've got a lot to learn from them. So it's not about changing the practice we have here. It's about learning from it and taking.
And I'm sure they probably have things to learn from us as well.
Of course.
Yeah. All right. What about your favorite condition?
Okay. So it happens probably at the other end of the scale. So your more term babies. I'm quite interested in HIE. So hypoxic ischemic encephalopathy. So those babies are babies that have an intrapartum hypoxia. So they have a lack of oxygen for some reason. It could be like a placental abruption, so where the placenta detaches and the baby doesn't get a lot of oxygen. It could be meconium aspiration. That's where their first bowel movement, they might inhale that and become hypoxic. I'm interested in it because the change in practice looking after these babies. So a lot of these babies, when I first started, and I'm talking over 20 years, they would pass away. They were very difficult to look after, difficult to ventilate, and often ended up with brain injury. So we found that by inducing therapeutic hypothermia, we could improve the outcomes for these babies suffering HIE.
So talk a little bit more
Okay.
about that. So what is the therapeutic temperature you're cooling a baby down to, and where did we learn that from? Has it always been something that they've wanted to do and just haven't, or have we learnt it from somewhere else?
I think it came from theoretical just research, probably animal research. I'm not 100% sure on that. So there is not a lot of evidence in therapeutic hypothermia for preterm babies. So they've got to be greater than 35 weeks to start with. There's also a lot of contraindications or side effects from making a baby cold. So you can have coagulopathy, you can have bradycardia, apnea. We keep them cold for 72 hours. And the idea of that is to prevent reperfusion injury. So the condition I talked about before, NEC or necrotizing endocarditis, that can be thought of as a reperfusion injury as well. So it's where your brain hasn't had a lot of perfusion or oxygen, and then when the perfusion comes back in, when the baby's resuscitated or born or things like that, is when the damage can be done to the brain. So it's about decreasing the metabolic demand of the baby to transition to extrauterine life. And that often involves us taking over the baby's ventilation and other key survival things. So not feeding the baby because we slow down the intestinal motility.
You're really resting the baby's body and cooling at the same time.
That's exactly right. So that certainly increased the outcomes for babies that were suffering from HIE when they were born.
Yeah. So what's the criteria? What's the full criteria, and what do they have to meet to actually be able to be cooled?
Okay, so there's a few things. Well, it's the clinical picture of the baby. So they need to, I mentioned about being over 35 weeks, but the baby has to meet some, I guess, what do you call it? Laboratory.
Like in their bloods.
In their blood. So often the cord gases are looked at. So they have to have a base excess of minus 12. Lactate's not actually part of that, and a pH of less than 7. And also has to meet a assessment criteria called SNART scoring. And what that looks at is the encephalopathy of the baby. So it is a scoring that can be done over 6 hours. You've got a 6-hour window to make the decision to start therapeutic hypothermia. And you look at different things like the baby's tone, and then you describe whether it's normal or whether it's moderate or whether it's severe. And so from that score, as well as your clinical picture, your clinical pathology, then you can make a decision on therapeutic hypothermia. It's something that needs to be discussed with an expert. So a neonatologist needs to make the decision for therapeutic hypothermia. As I said, it's not without its adverse effects.
You're sort of weighing up the positives and negatives and seeing
risk versus benefit. That's right. These babies sometimes get pulmonary hypertension as well. Can be difficult to manage. So the therapeutic hypothermia should always be done in a tertiary centre, a high level of neonatal care, because afterwards they need to, around day 5, we do an MRI to look at if they've had any brain injury or hypoxic injury to the brain after we rewarm them.
Yeah. So, and not only that, we have the equipment available in NICU.
That's
so
right.
There's actually a special piece of equipment that will monitor the baby's temperature.
Absolutely.
And change the water temperature depending on the baby's temperature.
Yeah.
That's right. When I started out, it wasn't a thing, therapeutic hypothermia, and then it became a thing. And we used to put cold gel packs around the babies to try and cool them down. And it was a really difficult
I
thing
could
to
imagine.
achieve.
Yeah.
They would
Keeping
get
them
too
at
cold
the-
and then they would
yeah.
get too hot. And
You're chasing all the
Yeah.
time.
chasing all the time, difficult to manage. The babies were uncomfortable. And now that we have this special equipment, it's essentially a water bed that circulates different temperature fluid around depending on what the baby's core temperature is. So it will either heat up or cool down automatically.
Yeah.
Which is a lot easier. Then you can set the machine to rewarm the baby over 12 hours as well.
And it rewarms slowly.
Slowly is the key.
So what's the evidence like between a mild to moderate HIE versus a severe with the hypothermia? Is it effective for all types, or is it more effective for some types other than others?
So if you score mild, the therapeutic hypothermia is probably not recommended. So it's for moderate and severe. It certainly increases the clinical outcomes for these babies, and they'll be obviously followed up in growth and development clinics to ensure they meet their neurodevelopmental milestones later on in life. So Mary might be a good guest for you to have for that. She's doing
Absolutely.
a PhD on it. So yeah.
That's excellent.
Amazing.
Yeah, it's really good. Thank you so much for coming on, Meg. We really, really appreciate your time.
Oh, you're welcome.
thank
You're
you so
amazing,
much.
and I'm sure everyone will see from this podcast the amazing things that you do
Oh,
and you continue to do every day.
thank you for inviting me, girls. What you're doing is really special. Thank you for letting me be a part of that.
All right.
You'll be
you.
back.
You'll see her again soon, guys. All right. Lovely.
Cool. Thanks.
Bye.